Good morning, everyone, and thank you for joining us on our 6th webinar on inflammation and psychosis. My name is Giuliano Tomei, and I am one of the research assistants working on the SINAPPS 2 and PPP2 studies, and together with my colleagues Danielle Smith and Isobel Harrison, we'll be chairing today's webinar. Before I hand over to today's speaker, a few details about the structure of this webinar. We will have an initial 20 minutes presentation, followed by a 10 minutes Q&A session. As all attendees are muted to avoid background noise, please feel free to submit your questions using the Zoom chat throughout the presentation. Questions that we will not manage to answer during the Q&A session will be then collected in a document which will be circulated together with a feedback form a few days after the webinar. Please note that all these webinars will be uploaded on YouTube and are freely available for you to view again or to circulate to your colleagues. So without further ado, it is my pleasure to introduce today's speaker, Professor Peter Jones, Professor of Psychiatry at the University of Cambridge and consultant psychiatrist at the Early Intervention Unit of the Cambridgeshire and Peterborough NHS Foundation Trust, who will give a presentation titled Neurodevelopmental Precursors of Psychosis and Their Relevance to Clinical Practice. So, Professor Jones, over to you.
Thank you very much, Giuliano, and to the SINAPPS team for arranging this webinar, and good morning, everyone. These webinars, as you'll know, those of you who've been to more than one, are primarily about inflammation and psychosis, but they also patrol the interface between psychiatry and neurology, and that's what I want to do with this talk today on neurodevelopmental precursors to psychosis. Can we have the next slide, please? So I want to give you a little bit of a historical perspective, think about these in a developmental way, and then talk mainly about neurological soft signs, but a little bit about minor physical anomalies. Think about how we can measure these in clinical practice, and then perhaps most importantly, what the clinical implications are of these characteristics in our patients. The next slide, please. So I haven't just pulled this out of a hat. There is a historical perspective that, like many things in psychosis and schizophrenia, goes all the way back to Kraepelin. And Kraepelin noted motor developmental differences in children who as adults would develop what he called dementia praecox. And he described motor abnormalities in patients with dementia praecox. And if that was schizophrenia, of course, that's long before the antipsychotic medication and the possible confounding by D2 blockade. And in some of his later textbooks, editions of his textbooks, there are beautiful drawings of patients with motor abnormalities, dystonic posturing, etc. So a few decades later, a woman called Barbara Fish, who I always think of as the sort of Rosalind Franklin of this field amongst Watson and Crick, Barbara Fish was amazingly prescient in thinking during the 1950s about the implications of genetic risk for schizophrenia, or what she was calling schizophrenia, particularly early onset schizophrenia, and noted in very detailed observational studies that babies who were at high genetic risk because of their parents having schizophrenia, they went through their developmental milestones rather differently. And she began to coin, after a couple of decades of studying this, the term pan-dysmaturation, which is still highly relevant today. And then in the 1980s, as I was coming into psychiatry myself, Daniel Weinberger and independently Robin Murray and Shone Lewis were beginning to pull evidence together and write about the concept of a neurodevelopmental hypothesis of schizophrenia. And as I say, this is just as I was coming into psychiatry. And evidence has begun to accrue from epidemiological studies that don't have clinical biases that there are all sorts of differences in early neurodevelopmental domains such as motor development, speech, cognitive and behavioral development that you can identify in people who will later develop schizophrenia. So I'll give you an example of this in the next slide that shows that there's a sort of prima facie case for something motoric going on early in life in people who will develop schizophrenia. So this is a figure from a study in a birth cohort in northern Finland. This is 12,000 Finnish people who were in utero, who were due to be born during 1966. And at age 1 year, around about 1 year, the mothers and babies went to a developmental check, and the mothers were asked when their babies reached a number of milestones, and particularly motor milestones. And here we've got the question about when they were asked about when the baby could stand without support. So hold by the wrists a toddler, let go, and the toddler can remain standing. And then what the researchers did in this cohort, and here I'm just showing you little boys for the sake of brevity, they looked at the amount of schizophrenia that arose in those babies decades later, right up into the early 30s. And what they've done here is to stratify those Finnish toddlers into 4 groups. So those who could stand without support really rather early, at 9 months, those are the pink diamonds. A little bit later at 10 months or at 11 months, or those who could not yet stand without support at the age of 1 year. And the amount of schizophrenia that arose in those 4 groups over the next 3 decades is summarized by the slope of the line. And you don't need any fancy statistics to show that if you were a later developer, then you're more likely in this Finnish population to develop schizophrenia over the next 3 decades than you are if you're an early developer. So, as I say, prima facie evidence that there's something going on in the motor system that is happening decades before people develop schizophrenia, but has something to do with risk. So let's go on to the next slide. And think about the clinical presentations at the onset of what gets called primary psychosis in the current operational classifications of ICD and DSM. So in terms of taking a history, you might be looking for delayed childhood milestones and abnormal social development. And in an examination, we might be looking for neurological soft signs, which in some series are remarkably common in schizophrenia, around about 50 to 60% versus 5% in healthy controls. And also so-called minor physical anomalies, things like high arched palate. So let's look at those 2 things separately. Next slide, please. Firstly, neurological soft signs. Well, what do we mean by these? They're basically things that you can identify by going beyond a standard neurological examination. So they're non-localizing neurological signs. So they're not due to a single lesion, as in a classical neurology. They're due to more integrative effects. And these are often grouped into signs about sensory integration, motor coordination, motor sequencing, and often they're just presented by adding up the number of these soft signs. So we've got sensory integration phenomena like dysgraphesthesia, where people are unable to identify letters or writings that's drawn onto their skin, usually the palm. They can't recognize that as writing. Poor motor coordination, problems with complex motor sequencing like dysdiadochokinesia, this phenomenon where you're asking people to alternately tap perhaps their palm onto their forearm and sequence the way that they do that. You've got persistence of so-called infantile or primitive reflexes, such as the palmar mental reflex. This is where if you scratch someone's palm, they'll pout. You get contraction of the muscles around the mouth. Abnormalities in blink rate, and a positive glabellar tap like you have in Parkinson's disease, where if you tap the glabella between the eyebrows, that people will continue to blink. So that's quite interesting because that has overlap with another dopaminergic disorder. Now one can understand soft neurological signs. As I say, they're non-localizing, so it's not a single lesion, more likely to be due to neural network abnormalities, and they may be very similar to the sorts of differences that might underlie those differences in the rate of motor development in young babies, just as I've shown you from those Finnish data as an example. Those are highly replicated findings around the world, actually. And these neurological soft signs are also independent of symptoms. Symptoms can come and go, but neurological soft signs tend to persist, and they're not related to antipsychotic drug dosages. And as I'll come on to later, they tend to predict poor clinical outcomes. Next slide, please. So how would you measure these in clinical practice? Well, I think the most important thing is to choose a measure and get some practice with it. So I've just put two here. The top one is not only because I come from Cambridge, but the Cambridge Neurological Inventory is actually a neurological assessment, a structured neurological assessment that's designed for psychiatric practice in general, not just for schizophrenia and psychotic disorders. And the second part of that focuses on these primitive reflexes and sequential movement, sensory integration. I'll put the reference there. Another one that's got traction in research, the Cambridge Neurological Inventory is very much a clinical instrument. In research, this scale by Bob Buchanan and Heinrichs and colleagues, Neurological Evaluation Scale for Schizophrenia, has got traction. There's a lot of research papers using that. So my advice is just to choose something and practice it. Let's go on to the next slide, please. So another domain of neurodevelopmental difference that we can pick up in clinical practice are so-called minor physical anomalies. And these are thought to represent fossilized evidence of differences in fetal development, and they're often to do with the hands, feet, the head, particularly the midline. So things like high arched palate, curved or abnormally spaced fingers and toes, abnormalities of hairline, low set, unusually shaped ears. And again, there are rating scales. They tend to be rather longer, more research focused than for neurological soft signs. But reading some of these assessments, you can begin to build in this in the way psychiatrists are very good at just observing. You can begin to build in looking for these into one's clinical practice. So careful, both of these things are about careful physical examination. Let's go on to the next slide, please. So I mentioned another domain, which is a little more subjective, and this is about differences in psychosocial development in people during childhood before they will go on as adults to develop schizophrenia. And there are scales. Again, this one, the Pre-Morbid Adjustment Scale, was really designed for research, but is readily translatable into clinical practice, just asking questions, particularly using informants, thinking about social accessibility, isolation, peer relationships during childhood, ability to function outside the home compared with the nuclear family, and for older children, the ability to begin to develop psychosexual relationships. So you can structure history taking into these different domains and think about different periods in development. And these will be anchors to be able to fill in information about psychosocial development. And I've given some references there to the classic Cannon, Spohr and colleagues pre-morbid adjustment scale that was updated for research and clinical use by Jean Addington and Steve Van Maastricht. So again, if you want, you can take a look at these and just practice for your clinical work. Next slide, please. So why and how are these neurodevelopmental factors important? Well, they can help us with diagnosis of a primary psychosis. So sometimes, as we know, we'll be assessing a patient with an insidious onset, not very verbal. The phenomenology is hard to come by, and positive psychotic phenomenology may be rather scant. And if you can build in evidence of neurodevelopmental abnormalities, then that might strengthen a case for a diagnosis of primary psychosis where things are difficult. It's just more information on the table. Alternatively, a careful history and physical examination may lead one to a diagnosis other than primary psychosis. So looking at a host of minor physical anomalies, for instance, that fit into a syndromal picture may point one away from primary psychosis towards other developmental syndromes such as VCS. What you're looking at when you identify neurodevelopmental factors may be the direct precursors of negative symptoms. Now, we know that at onset, negative symptoms, if we look, they're actually there quite commonly in first episode psychosis. But again, you can see these in a broader picture if you sketch in the neurodevelopmental factors. So differences in speech development in childhood, for instance, may have a direct continuity with alogia and speech disorders at first onset. So this may help one's clinical formulation and understanding, and I think that understanding can be in a developmental context as well. So if your history taking has shown that a child had a lot of developmental difficulties in making friends, school attainment problems, then you can begin to see that that patient in front of you may decades beforehand have had very different psychosocial experience. That may be something you can think about in the formulation of the patient's problem. But I think the most important thing is that they guide prognosis cheaply and possibly more effectively than more specialized examination. So we know for some decades now that neurological soft signs in particular are associated with poor prognosis. And I told you that when I came into psychiatry in the 1980s was a time when there was a lot of interest in neurological soft signs and neurodevelopment. And I was involved in studies where we were measuring MPAs and neurological soft signs, and I rather left it recently, but until recently. But one of the big UK first episode psychosis studies, the Isobel study, completed a 10-year follow-up some years ago, and we showed that in patients who after first onset over the next decade were less likely to remit, regardless of what drugs they'd had or their symptomatology when they were unwell. At baseline, we could identify those from the presence of neurological soft signs. So not only are you looking at a summary of development until you measure these at first onset, but you may be able to use these prognostically. And what's the practical point of that? Well, of course, knowledge of the future is something that we all thirst after, but not least at the moment. But I think of this in clinical practice as perhaps pushing us even further towards considering the use of clozapine early on in first episode psychosis. It's known that we're really rather loath to do that when we probably shouldn't be. So next slide, please. So at the same time as I was involved in this follow-up of the ESOP study, I've also been involved in the writing of an article for World Psychiatry on the clinical characterization of patients with primary psychosis. And I summarized the developmental implications in that piece that's coming out, I think, next month in World Psychiatry. And it's really that article that I've used as the text for this talk. So next month, if you get that publication, you'll be able to see that as well as look at these slides. And I'd be very happy to answer any questions. Thanks very much.
Thank you very much, Peter, for this great presentation. And as you mentioned, I will then hand over to my colleague, Danielle, for the Q&A session. Danielle, please. Thank you.
Brilliant. Thanks, Giuliano. Got a question here for you, Peter, that's talking about sort of nature versus nurture, and asking specifically, would it be possible that these neurodevelopmental signs that you've talked about might arise as a result of neglect as opposed to more kind of biologically determined causes?
Very good question. Nature and nurture undoubtedly go hand in hand. I think some of the I think even from prenatal factors, we know that maternal experience can affect the development of the unborn child. So, you know, in short, just to cut to the chase, I think that's quite likely, and we shouldn't think solely about biological determinism. Although, as I say, some of the ideas, such as those in the 50s, 60s and beyond, were very much about genetic risk playing out. So I'd say yes, and almost certainly both nature and nurture are involved.
Brilliant.
You know, because there's also concepts like rescue from these. So what's not studied very well are children who are developmentally off track, but may get back to their developmental trajectory. And one might presume that they lose that excess risk of serious mental illness as they get older. And that could well be a nurture effect, a positive nurture effect. So, you know, nurture can be both positive and negative. It's a good question.
Definitely. Yeah, I mean, that's something, yeah, it just highlights to me the importance of early intervention in these kind of individuals. Do you know about any research maybe that has explored you know, specific interventions with the individuals that have shown these soft signs, and maybe then comparing what the outcomes are for these individuals?
Yeah, that's another good question. So there have been studies, and again, so that work from Barbara Fish back in the 1950s, that was really the precursor to decades of what got called genetic high risk research. So studying the offspring of people who had serious mental disorders, largely schizophrenia, but not only schizophrenia. And that did lead to a range of intervention studies. So things like the New York High Risk Project. And there were interventions tried in those children. And I think the honest answer is that they went into the sand. They're very difficult studies to do because you get an enthusiastic group of clinicians and researchers who begin looking at children. And to find out the results of that work, you may need to follow them up 30 years.
Yeah.
So you're almost looking at the children of the clinicians and the children of the researchers. But I would say that one needn't only think only of schizophrenia and mental illness as outcomes. So these high-risk children are likely to be at risk for a whole host of suboptimal outcomes. So, you know, I think again there is a sort of there's a face value to intervening early and throwing the kitchen sink at trying to get children back on a developmental track so that they do better at school, they do better in terms of friendships, social capital, and better outcomes in the teenage and early adult years.
Brilliant, thank you for that. Got a few questions in from the team. So Isabel's asked, is there any relationship between the presence of neurological soft signs and pre-morbid IQ?
Good question. So I didn't really mention pre-morbid IQ, and IQ in general is somewhat contentious, but there's very consistent and robust evidence that as children, people who will develop a range of serious mental illnesses, but probably schizophrenia and psychotic disorders mainly, have or perform less well in tests of school attainment or tests of a concept of G or intelligence during childhood. And one would predict that neurological soft signs would be associated with deficits in childhood IQ or pre-morbid IQ. And there's a little bit of evidence for that. There's certainly evidence that those motor abnormalities in childhood are associated with the whole, this is what pan-dysmaturation is, it's a cluster of developmental differences. But the types of study, more clinical work that you measure neurological soft signs, you tend not to have very good measures of pre-morbid IQ. You're relying on things like a NART score, which is a pronunciation test, really. So very indirect measures. So theoretically, you think they'll be highly connected. Empirically, there's some evidence that they're connected, but it's quite difficult to show that.
Okay, thank you. Got another question about gender differences in this area and the kind of research area. Just considering things like autism can present very differently in girls as compared to boys. So just what are your kind of thoughts on that?
Well, another very good question, actually. So the a priori hypothesis would be perhaps that these developmental abnormalities will be more common in boys. But actually, if you look, if you're looking through a schizophrenia lens or a psychosis lens, if you look at the evidence, then there's not really a strong evidence for that. You see them in both boys and girls. Clinically, the classical picture of pre-morbid developmental abnormalities, I think we pick that up more in boys, and that may be because their presentations might be more obvious. But when you're looking at finer grain detail in population studies, then you do see them in boys and girls. And I suppose that comes back to the questioner's point about difference in developmental presentations between boys and girls. So the a priori hypothesis would be more boys than girls, but you don't really see that when you've got very detailed evidence. They're just different presentations.
Okay, brilliant, thank you. I think just for time now, we'll have to hand back to Giuliano just to finish off the webinar.
Thank you very much, Danielle and Peter, and thank you everyone for attending this webinar, which marks the end of this webinar series. We hope you enjoyed it. We certainly enjoyed delivering it to you. And we are delighted to say that while we might take a summer break, we plan to be back in autumn and winter with more webinars on these and other topics which are relevant for neurology and psychiatry. So make sure to subscribe to our YouTube channel and stay in touch for future updates. Once again, thank you very much and enjoy the rest of your day.